Welcome to the Trinity Health IHA Medical Group Wednesday Wellness Series. This presentation is titled Understanding Addiction, Dependence, Treatment, and Recovery. And our presenting providers are Trinity Health IHA Medical Group Addiction Medicine physician Mark Weiner, who serves as the Section Chief of Addiction Medicine, Medical Director of Substance Use Disorders, and Program Director of the Addiction Medicine Fellowship Program at Trinity Health Ann Arbor. And our other two presenters are currently addiction medicine fellows at Trinity Health Ann Arbor, Dr. Lorien and Dr. Cicely Moreno. Welcome, Dr. Weiner.
Thank you for the introduction, and welcome to all the participants. Thanks for joining us today. We're going to talk about addiction. I was talking with Allison earlier, and we said it's probably rare that we find anyone who isn't either personally affected or knows a friend or family member affected by addiction. So it's a very kind of relevant topic, although it's not really talked about very much. Again, I'm Dr. Mark Weiner. I am addiction medicine specialist and also the director of the Addiction Medicine Fellowship. I have the honor today of having two presenters, Dr. Moreno and Dr. Shack, who are the Addiction Medicine Fellows, which means, if you don't know what that means, that they won the interview lottery and get to work with me and the faculty for a year to become addiction medicine experts on their own. And they're gonna speak. I am gonna just let you know a little bit about what's going on. The order of things, we're gonna have Dr. Moreno start talking about, well, let me share my slide, hold on. I'm a little bit off base there. All right, Dr. Moreno, who will be talking about nicotine and cannabis addiction, and about treatment resources and treatment options for people who are dependent on those substances. Dr. Shack will then talk about alcohol use disorder and opiate use disorder and treatment options for those. And I will finish up talking a little bit about an update on the opiate overdose crisis and opiate-related deaths and other drug-related deaths, and a very important topic about Narcan or naloxone rescue, which will hopefully give someone out there an idea of what they might be able to do if they are present at an overdose. And there may be a way to actually save someone's life, which is pretty straightforward and a pretty amazing thing to do. So I am going to stop sharing and turn over this talk to Dr. Moreno.
Good morning, everyone. I am going to be, as Dr. Weiner mentioned, I'm going to be talking about nicotine and cannabis use. And so I'm going to share my screen. All right, so we're going to be talking about the current trends, the dangers and treatment options for nicotine and cannabis. And I'll explain why do we care about these two substances. Okay, so nicotine use in the US in the form of cigarettes overall has declined in the past 50 years. However, tobacco use remains the leading cause of preventable disease and death in the U.S. So about 46 million Americans in the U.S., about 18.7% use any tobacco product. That includes cigarettes, e-cigarettes, cigars, smokeless tobacco, pipes, and hookah. And smokeless tobacco is the chew or cud, as the different names for snuff is another term for smokeless tobacco. Those are all included in that type. When it comes to any type of nicotine or tobacco use, it's more common in men, people who are younger than the age of 65, the white population, people who have lower education and lower socioeconomic status, mental illness. For example, people with schizophrenia have been known to use cigarettes more heavily, disability, and also the LGBTQIA+ community. So when it comes to adolescent trends, about 10% of students aged 12 to 18 have reported to use any tobacco product. Although high school students have reported to have a decrease in use. So it's declined from 16.5% in 2022 to 12.6% this year. There's an increase in middle school students using tobacco and e-cigarettes. So that is really important to note. So its prevalence is increasing in a younger population. E-cigarettes are the most popular, while cigarettes, which are also termed combustible tobacco, and cigar use are declining. And why is this trend? Just to speak about e-cigarettes, they are given in multiple flavors. They don't have a taste that might be more unfavorable. They come in different like fruit flavors and candy flavors. So these become more attractive to adolescents. And so when it comes like, what are we doing about this? Students have reported seeing anti-tobacco public education campaigns in the last year. About 75% of students who reported they used tobacco, they did report that they did see these campaigns, but there's also exposure in the social media to e-cigarette ads around the same percent. And these ads have been known to be colorful, to be trending, to be very appealing to the adolescent population. So as I talked about, more than 2.1 million youth use e-cigarettes. As I mentioned, there's a decline in high school students, but an increase in middle school students. And 9 out of 10 use these flavored e-cigarettes. These are the type of brands on the market, with this Elf Bar brand being the most popular. So, and then 1 in 4, so 25% reported daily e-cigarette use. Now, why is this important? So let's compare e-cigarettes first to nicotine, the nicotine concentration. Let's compare that to the amount in an actual cigarette. So it's actually really hard to do, but just to give you an example, most cigarettes have about 10 to 12 milligrams of nicotine in each cigarette. And a smoker, if you aren't familiar with a cigarette, there is a filter at the end of it. And the filter, if depending on how the person puts their lips on the end of the cigarette, how they inhale the cigarette, will literally determine how much of that nicotine is absorbed. So if someone takes a huge drag, as they say, then they're going to absorb more nicotine than someone who takes a lighter inhalation. And so, but in general, a smoker is getting about 10% of this nicotine. There are over 460 e-cigarette brands on the market, and they come in a wide variety of nicotine concentrations, from ranging of 0, if someone's using a non-nicotine e-cigarette, to 87 milligrams per milliliter. And that is quite a hefty amount. And so these nicotine strengths vary. And so then we cannot quantify how much a person is using, how much nicotine a person who uses an e-cigarette is getting, but we can have an idea for this example. Let's say someone has a 20 milligram per milliliter vape pen or e-cigarette with 2 milliliters of vape juice or the e-cigarette liquid, then they'll have 40 milligrams of nicotine in that pen, which is equivalent to smoking about 1 to 2 packs of cigarettes. So it also depends on how many puffs are they getting in the e-cigarette. From what I've read, you can get anywhere from 100 to 300 puffs in a 2 milliliter vape pen. Once again, depends on how much the person inhales. And so Juul Labs did release a study that was then verified by another independent study, which showed that Juul Labs did report that in their 40 milligram pods for their e-cigarettes, they're equivalent to about 1 pack of cigarettes. And an independent study did confirm this. However, as you see from the picture here, there's varying size, shapes, concentrations, even the coiled mechanism in an e-pen is varied, and some are considered slow heat up coils, some are considered like rapidly heating coils. And there's no filter like there is in a combustible cigarette. So it's thought that the nicotine is inhaled faster and more efficiently in vaping. Therefore, you are getting a higher and faster nicotine delivery than smoking a cigarette. And then also when it comes to this vape juice or this e-liquid, studies have found acetaldehyde, acrolein, and diacetyl and formaldehyde. And as the ones with the asterisks by them, these are actually carcinogens. And the other two are harmful toxic substances to the body. So why is this important when we talk about e-cigarettes? Adolescents, use of e-cigarettes has led to a 3-point time more likely for them to use cigarettes later on in life. So it is a entry and to using actual combustible cigarettes. Nicotine and tobacco have been shown to harm the adolescent brain, especially in parts that control attention, learning, mood, impulse control. Also, there was a study done by a group of pulmonologists who found that e-cigarette use was associated with increase of wheeze and asthma in adolescents who were never smokers. So also nicotine targets the brain in a way that is unique than other substances, in that it causes the reward system. So if you can imagine, for when we receive an award, like you get a new job that you worked hard for, you got a good grade in school, it makes you feel happy and you release dopamine. With nicotine, having that rapid, fast delivery of nicotine in an adolescent brain triggers that reward pathway much quicker than, for example, a achievement in life that triggers dopamine. And so therefore, that signaling is rapidly triggered to release a high amount of dopamine, and the adolescent brain is primed to learn that substances can do this and make me feel reward and trigger and make me feel happier quicker than a life achievement. So therefore, this changes this changes the brain signaling for reward and for increased mood, and this leads to use of other substances later on in life. So I'm going to talk now about cannabis use, and then we'll talk about a little bit about both cannabis and nicotine use and the treatment options for both. So when it comes to cannabis use, as you know, we live in a state where marijuana is legalized. Throughout the whole U.S., 55 million adults have reported that they use marijuana, and that's higher than the actual amount of people who use tobacco. And then almost half of all the adults in the United States have reported they've tried marijuana at least once. Studies have shown marijuana use is higher in states where cannabis is legal. And so about 20% of residents in Michigan reported that they use cannabis, which is higher than a national average. The national average is around 17%. So cannabis use in Michigan has grown by 75% since 2010. And just to give you an idea how much, this is a very, very lucrative market for the state. And Michigan's on track to reach $3 billion in sales this year, becoming second only to California. As of 2023, 24 states have legalized cannabis use for recreational use, and also 38 states have allowed medicinal or medical marijuana use. For example, in May this year, Minnesota was the 23rd state to legalize cannabis, and then Ohio became the 24th state earlier this month. So in a recent poll around of parents of the Metro Detroit area, there was 1,700 parents who reported, 42% of them reported that they choose cannabis over alcohol instead of to relax. And I'll indicate why this is important in a minute. Okay. So adolescent trends when it comes to cannabis use. More than 1 in 3 teens, so 38.3% reported they've tried cannabis by the 12th grade. 70% of 12th graders reported that cannabis is easy to obtain. So when it comes to parents choosing marijuana over alcohol to relax, the 12th graders reported that was where they had gotten it from. They had gotten it from their parents. So that's why it's really important. Both of these substances is more for a adolescent than just trying cannabis or nicotine alone. So that's really important. So also, young people who use e-cigarettes are 3 times more likely to go on to use cannabis than those who don't. So that's another important data point to note. And then just like nicotine, cannabis also, when we talk about that dopamine reward pathway, is also shown to have lasting effects on that reward system and on brain signaling, because the brain doesn't mature until the age of 25, at least for adults. And then more than 66% of high school seniors said that they use cannabis daily. And then 2.5 or 1 in 10 U.S. teens reported that they use cannabis on a casual basis, meaning at least once a week. 2.5 million, excuse me. And then, so of this amount that use cannabis, there more than 600,000 teens meet the criteria for an actual cannabis use disorder. And so, what is a cannabis use disorder? So you might be familiar with old terms as addiction or dependence or abuse or misuse, but the Diagnostic and Statistical Manual of Psychiatric Disorders, the DSM-5, is what psychiatrists use to diagnose mental and illnesses, and also other illnesses such as substance use disorders. And just going over that criteria to understand what makes a diagnosis for a use disorder. For the sake of this talk, we'll talk about cannabis specifically, but these all 11 criteria do apply to any substance. So you have to use the substance for long periods in large amounts. You feel like you can't cut down on using. For example, you are craving the use, can't cut down. You spend a lot of time in getting the substance, and then not only getting it, but using it, recovering from it. Strong urge or cravings to use the substance, problems at work, school, and with relationships and family. And then you just continue to use despite knowing the negative consequences it has socially and interpersonally. So problems with friends and parents, if we're talking about teens. And then decrease in important social and recreational activities because of use. So let's say once the child wanted to do soccer and play the piano, they no longer want to do that. They rather use cannabis or e-cigarettes. And then using the substance in dangerous situations, such as like smoking cannabis and driving, or something like that. And then using despite worse physical and psychological problems. For example, we'll talk about in a minute how cannabis increases the use of increases risk of mental illness, psychosis, a vomiting syndrome. And knowing these, and you still continue to use the substance, would then also be one of these criteria. You're needing to use more of the substance to get the same effect. So maybe, you used cannabis when you first started, maybe 1 puff or so made you achieve a high, but now you find yourself needing like a whole more than 1 puff and a whole a new amount than when you first started. And then a withdrawal reaction. So when you stop the substance, you might feel worse than when you're actively using the substance. And so you need at least 2 of these criteria to have what we call a cannabis use disorder. And then when we talk about addiction, there's many terms and many definitions, but how we define addiction as addiction medicine doctors, it's a treatable chronic medical illness and that's involving complex interactions in the brain, among brain circuits, the genetics, and the environment in an individual. And it also includes life experiences. For example, trauma is a life experience we take into consideration. People with addiction may be engaged in behavior that becomes compulsive, and they continue to use despite harmful consequences. Also, when you think about addiction, there is a physical component in which the body becomes dependent on the substance. And when the substance is taken away, then the body goes through withdrawal, not just the body, but also the mind. So what are some dangers about cannabis that we need to know about? So it's reported that for anyone who uses cannabis, adults, teens, everyone, up to 30% can develop a cannabis dependence, so physical dependence, or a use disorder. And why is this so? This number is increasing, and it's thought that the THC content that's in marijuana and cannabis is not like it used to be. In the 1990s, it was about 2%. Then after that, it grew to 4%. And then between 1995 and 2015, there was a 212% increase in the THC content. And this is, with genetic modifying of cannabis. And so right now in Michigan, average THC potency is anywhere from 18 to 23%. But I've heard patients tell me that they've seen a content as high as 50, even 65%. And so that's dangerous. So because it's such a high potency, it is considered more addictive. You develop more of a dependence on it. And there's a fourfold increased risk of addiction. And with use for teens, adults alike, you still suffer some cognitive deficits, problems with executive functioning, so decision-making, also processing decisions at a certain speed gets delayed, your attention's delayed, memory is impaired, judgment, planning, problem solving, and self-regulation. So impulse control is also affected. Other complications include delirium, psychosis, anxiety, and problems sleeping. So someone might say, oh, cannabis helps me sleep or helps with my anxiety, but use can actually worsen those symptoms over time. And then another thing that's been shown is that as each state is going on, more and more states go on to legalize marijuana, and cannabis use has been decriminalized. Adolescents start viewing marijuana as less and less harmful. So over the past 10 years, a number of adolescents who thought cannabis wasn't harmful has increased by 50%. So exposure, as we talked about, to adolescents primes the brain for addiction. Not only that, cannabis use in teens has been shown to also increase the risk of poor grades, law breaking, physical aggression. And then also they've shown that teens who use cannabis are 2 to 4 times likely to develop a mental illness, contributing to the increased risk of depression, suicide, and ADHD. And then there's also a 4-fold increase in adult psychosis diagnosis over time. And I just want to point out, it was previously thought that this increased risk of psychosis was possibly related to having a genetic component. For example, my mom has bipolar, my uncle has schizophrenia, therefore I might have increased risk of those diagnoses if I use cannabis, versus someone who uses cannabis and there's no family history. There's now studies that have shown that that's not the case. The increase in psychosis is there regardless of family history. So what are our treatment options for nicotine use and tobacco use? So there are 2 medications on the market. One is varenicline or Chantix, and that is a nicotine agonist. It binds to the nicotine receptor, and it works to give it works as a replacement to nicotine or cigarettes or e-cigarettes. There's also bupropion, which is also known as Wellbutrin. It targets dopamine and norepinephrine, and it is also an antidepressant, and it's also shown for treatment of adult ADHD, but it also is used as an option for stopping tobacco and nicotine use. And there's nicotine replacement therapy that's in the form of a patch. There's gum, there's lozenges, there's even an intranasal spray to help give nicotine instead of cigarettes or e-cigarettes. And why is this a better choice over smoking a cigarette or e-cigarette if you're getting nicotine? Well, as I mentioned before, with the e-cigarettes, there's many toxic and cancer-causing chemicals in the liquid. And with cigarettes, there's over 600 carcinogens in a cigarette alone. So this is a much better option than smoking or using an e-cigarette. So what do we do for teens? If you find out your teen is smoking cigarettes, using e-cigarettes, the first intervention for kids is you want to try counseling in a way where it's motivational, cognitive behavioral therapy, social intervention, and those have been shown to be effective when it comes to teens and obtaining abstinence. I see a hand raised. Go ahead. Oh, okay. Well, you go ahead.
I was just saying, people are actually muted. If you have a question, please feel free to type it into the Q&A feature and we'll answer them that way.
Okay.
Sorry.
I'm going to wrap this up. I have one more slide and then I'll answer that question. So, nicotine replacement therapy. So these medicines and Wellbutrin, not Chantix, might be actually an option for adolescents who are really have a nicotine or tobacco use disorder, and counseling is not effective on its own. Then at that point, I encourage you to talk to your child's doctor and discuss these medications, and which might be an option for the teenagers who are using nicotine or tobacco. There's also this text quit to this number 47848, and it's offered by the National Cancer Institute. I actually tested this number, and what they do is they ask for your age, they ask for several questions, demographic questions, and then they try to locate a counselor in your area. So, and it's not just for adults, it's also for teens. So that's another option. And then there's local resources too here in Ann Arbor. The Washtenaw Health Department for kids under the age of 18 is called the My Life, My Quit program. It's confidential, and they will offer tools for youth who want to stop using any tobacco products. There's the phone number, and they can also enroll online. And then adults, there's the Michigan Tobacco Quit line at 1-800-QUIT-NOW. And they offer free services if you're uninsured, Medicaid, Medicare, a veteran, cancer patient, pregnant, and Native Americans. And then for cannabis, once again, the recommendation is counseling. Talk with a doctor, addiction medicine specialist like ourselves. U of M does have a program for teenagers, and then there's also, we also will see adults and teens through IHA recovery medicine here at Trinity Health. There is if you're familiar with Alcoholics Anonymous, there's actually a marijuanaanonymous.org, and they offer online support groups. And then when it comes to medication options, for nicotine cessation, like I talked about, Chantix and Wellbutrin, those are FDA approved treatment options. There are no FDA approved treatment options for cannabis, but N-acetylcysteine, this is a compound that is actually produced in small amounts in the body, and it's an antioxidant. It has been shown to be effective in promoting abstinence and reducing cannabis use among people who would consider themselves dependent. All right, and that is all I have for me. I'll turn it over to my colleagues.
Dr. Shack, you're up.
I am just waiting for Cece to stop sharing, if you don't mind.
Yes,
Thank you
I have
so
stopped.
much.
Okay.
All right. Okay. Assuming everyone is seeing that. Hi, I'm Dr. Shack. I'm going to be talking to you today about alcohol and opioid use disorder, the risk, the epidemiology, and the treatment. So with any topic, I like to describe briefly the relevance before I talk about the prevalence, which is the who, what, when, and how much. So why do we care about alcohol use? It's legal, right? Bacon is also legal and it tastes good, but we don't need to eat a lot of it all at once. Um, Alcohol is the fourth leading cause of preventable death in the US behind tobacco, diet and inactivity, and illegal drugs. In 31% of overall driving fatalities and 21% of suicides, the deceased had ingested alcohol. The most recent estimate of the economic burden of alcohol use is $249 billion. When you break this number down, it goes to $28 billion of cost in healthcare expenses, $179 billion in workplace related productivity, $13 billion in accidents, and $25 billion in criminal justice or legal issues. And this data is from 2019, and I'm sure that, as I'm going to talk about next, those numbers have increased since 2019. So if you look at the bottom figure on the right, you can see alcohol use in 2019, 2020, and 2021. Unfortunately, but expectedly, over the last few years due to the pandemic, there has been an increase in alcohol use measured by a 2.9 increase in sales. I'm assuming if people are buying the alcohol, they're drinking it or somebody is drinking it. Unfortunately, also an almost 10% increase in alcohol-related deaths occurred as well. So while robust data has not yet been published, there are many ancillary reports indicating not only was there an increase in frequency of alcohol use during the pandemic, but in the amount of alcohol consumed during each sitting when used. So there was a previous thought back in the early 2000s that a glass of red wine a day is beneficial for the heart. Recently, Journal of American Medical Association and Mayo Clinic have made statements saying that that may or may not be the case. I definitely don't want to demonize alcohol, but the health risks are real. Alcohol is an indiscriminate offender when it comes to the effect it has on the body. Some of those effects are long-term effects of use, like in the case of the liver, but the timing of the damage is highly dependent on the quantity of alcohol used by each person. So starting from the top, it can cause stroke, memory or speech impairment, difficulty with coordination, nerve problems, or long-term mental deficits. Although it's often used for anxiety, sleep, and depression, it can also, it can paradoxically have a deleterious effect on sleep, anxiety, and depression. There's also, when you go to the heart and cardiovascular system, there can be an increased risk of hypertension, heart failure, and arrhythmias. When you think about the gastrointestinal, you always think about the liver, which is very important and is involved in 50% of liver deaths, meaning just that people had consumed alcohol or on a regular basis. But it also can impact the pancreas, can increase the risk of diabetes, can cause stomach problems and ulcers, and cause problems with malabsorption of nutrients, which is really important. It is also linked to several types of cancer, like esophageal, stomach, breast, liver, colon, etc. And I didn't know this before I was looking at this presentation, but one episode of heavy drinking can impair the body's ability to fight disease for up to 24 hours. Lastly, pregnant patients, if possible, should avoid alcohol. There's really no, everyone's heard of fetal alcohol syndrome. There's really no benefit to drinking alcohol in pregnancy. Now that we know the why, let's discuss alcohol use in the US. So regarding past month alcohol use in the US, in adolescents, which we will define as age 12 to 17, 23% had used any alcohol at all. Young adults, which is 18 to 25, almost 50% used alcohol. And in all adults overall, 84% had used alcohol in the last month. Regarding binge drinking, which we will define on the next slide, 4% of adolescents and almost 30% of young adults and 23% of adults over age 18 binge drink. And regarding alcohol use disorder diagnosis, of which there's mild, moderate, and severe, disturbingly, at least it's disturbing to me, 3.4% of adolescents and 11% of adults carried a diagnosis of alcohol use disorder. So if you look at the figure on the top left, there's a definition of a standard drink. So often patients come in and say, I have 2 drinks a day. Well, what size, what strength of the drink are you drinking? Spirits, which if you say I'm drinking 5 ounces of spirits, that's a big difference between that and drinking 5 ounces of wine. So, and I have my funny comic on the right just to break it up a little bit. I drink 1 drink a day. So what is healthy drinking? Alcohol use for women is considered acceptable or healthy when it's less than 3 drinks a day and less than 7 drinks a week. For men, they get a few more drinks if they drink less than or equal to 5 or 4 drinks a day rather, or 14 a week. That's considered healthy or within normal limits for men. Moving on to binge drinking, which I mentioned on the previous slide, binge drinking is any pattern of drinking that increases your blood alcohol content by 0.08 in 1 drinking episode, so 1 sitting. This is typically 4 or more for a woman and 5 or more for a man, and usually within a period of 1 to 2 hours. And Lexley, we as Americans have been drinking so much that they have created an entirely new category of use. It's called high intensity drinking. And this is when people drink 2 or more times the binge drinking standards with 1 episode of drinking. So that means like 10 or more for males or 8 or more for females, women within 2 hours. And they have levels of it. So some people are drinking 3 or more times the amount. I didn't include heavy drinking, but for just for brevity's sake, but you might be saying, what if I have 5 drinks, but I space them over an 8-hour period? That would be heavy drinking versus binge drinking or high intensity drinking. So who is at risk for an actual use disorder? As Dr. Moreno mentioned before, those who start drinking at an early age are more at risk to develop an alcohol use disorder. Those who have family members with alcohol use disorder, and those who have mental health issues. So it's genetic and psychosocial as well. Some of those, so one of the first thoughts I have when I'm looking at a patient and they're saying, do I have a use disorder? I say, is the use of this substance causing you impairment or distress? So we break it up into criteria, as Dr. Moreno already said, mild, moderate, and severe, and there are a number of them. And I break it up into categories, the 3 C's, just to make it easy: craving, control, and consequences. So craving, are you spending more time obtaining, recovering from the use of your alcohol? Do you find you need 2 pints instead of 1 pint just to get the same result, etc. Control, are you needing alcohol so badly that you drink it despite the fact that you have to go get the alcohol and drive? Or are you putting yourself in a dangerous situation to obtain it? And then consequences, legal consequences, family consequences. Your wife is leaving, your dog doesn't like you anymore, you're having problems at work, your health, or mentally or physically, is impacted. So those are all things that we look at when we say, is this a disorder, or is someone just using alcohol within a normal realm? So to me, the goal of any treatment is to aid in the return of function, that the level of function that is best for the patient, not necessarily for the physician or the family members, but for the patient. Is patient-centric. And I like to look at recovery as pieces of the puzzle. So as you see on the right side, I have some puzzle pieces, but for the very first puzzle piece for alcohol, the first piece is safe withdrawal management. So whether it's done inpatient or outpatient, it should be supervised by an MD or a DO because there can be very bad side effects from alcohol withdrawal. So make sure that you're contacting, IHA Recovery or University of Michigan or Brighton or Maple Grove. Pick a recovery center with an MD, and if someone wants to withdraw from alcohol safely. So after withdrawal management, ideally the patient will be referred to a next level of care. So that can occur in many settings. It can be a residential level, intensive outpatient, a partial hospitalization, or even an outpatient situation. And that's another piece to the puzzle. Then recovery is a process. And I kind of think of it as not just puzzle pieces, but the Swiss cheese model. So all of these things on the right side are levels of protection. So say you have Swiss cheese, you stack it up, and you have multiple pieces of Swiss cheese. The more Swiss cheese you have, the less water or the less penetration you're going to have. So you add medications. You can use naltrexone, acamprosate, disulfiram. That's one level. Then you add on some behavioral therapy, whether it's cognitive behavioral, DBT, whatever. You add in mutual help groups, AA, Smart Recovery, Dharma, Refuge. And then a really important piece is the lifestyle, sleep hygiene, nutrition, physical activity, and mindfulness. Many people report drinking because they have anxiety or because they have problems with sleep. And so the healthy lifestyle will help assist with that. And so all of those pieces add up to some success, hopefully, with recovery. So now that I've belabored that, let's move on to opioids. Once again, I always start with the why. By far, the worst danger of opioid use is overdose and death. Unfortunately, as you can see on the left, overdose deaths in the US continue to rise. On the right, you can see the 3 waves of the opioid deaths over the last 20 years. The first wave was the semi-synthetic prescription opioid epidemic in the late 1990s and early 2000s. This would be your Norco, Vicodin, morphine, those type of medications. The second wave was beginning in the 2010s, and that was with heroin. Excuse me. And that's pretty self-explanatory. Heroin is heroin. And that can be snorted, injected, multiple ways of ingestion. And starting in 2013, the man-made opioids started to take over. So some of those were prescriptions, some of them were illicitly manufactured. This is your oxycodone and fentanyl analogs predominantly. So by 2016, as you can see, the source of synthetics, they overtook the heroin as and the semi-synthetic prescription opioids as the most prominent source of overdose deaths. This slide is Michigan specific. Go blue. Looking at the graph on the left, you can see the substance specific overdose rates. So as you can see, any opioids at all were in 83 or 84.3% of deaths involved at least one opioid, and a large percentage of those involved fentanyl or its analogs, and then a lesser amount heroin and prescription opioids. On the right is just a little bit different breakdown. This piece right here is saying they had opioids and stimulants, but the majority, 46%, were just opioids in overdoses in Michigan. Importantly, though, on the right towards the bottom, I want to point out that even though there's still work to be done, if you look at all the US for preventable overdoses, so this means like someone could have gotten there and given the patient Narcan or helped with respiratory intervention until help came. Michigan is at 47% of patients that could have had interventions compared to 66% at the US. So we're doing almost 20% better. So good for Michigan. We can still improve though. In addition to death and overdose, there are other physical complications. By far, infection from injection use would be the major complication that we see. And it can occur pretty much anywhere. There can be an infection in the heart, there can be liver abscesses. Skin infections are particularly common with injection, and even spinal infections, and then HIV or Hep C. Other common side effects would be constipation, which that can occur with correct use without any opioid misuse, or with opioid misuse. They can also cause stroke or seizure. Once again, we have the sleep disorders that can come as a result of the use, and also endocrine disorders such as sexual dysfunction, weak bones, and lastly, there's no safe amount of illicit opioid use in pregnancy, and it can cause neonatal withdrawal syndrome, which is when babies are born to women with opioid use, and the babies withdraw from the opioid after birth, just like an adult would. So lastly, there are many societal consequences of opioid use. Economically, in 2018, the cost was thought to be somewhere about $179 billion. This includes hospitalizations, lost labor, and legal consequences. Also, the cost to the families can be severe. Over a 15-year period from 2002 to 2017, the percent of children living with an adult who has opioid use disorder increased by 30%. And the children living with an adult who used heroin increased by 200%. This results in more children being removed from homes, which increases foster care costs and is just not good. So there's also been a 500% increase in neonatal abstinence syndrome since 1999. So lastly, there can be an increase in crime, but treatment has been shown to be effective in decreasing the rates of crime significantly. So when we think of opioid misuse, I think it's easy to paint the picture of a person with a needle in their arm using heroin. But as you see on the left, the majority, that big blue piece of the 9.2 million people who misuse opioids, use prescription pain relievers, or at least they think that they're using prescription pain relievers. The definition of misuse is using opioids, just by the way, because I've used that term a couple of times, it's using opioids that are not prescribed to you, or using opioids not as they prescribe to you. For example, if you're prescribed 4 times a day, you use them 10 times a day. And so those would be examples of misuse. And of course, using heroin or fentanyl would fall into that category of misuse. On the right, you can see the highest percentage of use was in those 18 to 25, but 2.5% of 12 to 17-year-olds misused opioids. And I don't have this on the slide, but the major source was from either parents or the friend's medicine cabinet. So lastly, this brings us to defining a use disorder. We've belabored this point, but I think it's especially important in opioids to define a use disorder. There's a difference between opioid dependence and opioid use disorder. Opioids are an effective medication for some chronic and life-threatening or hospice level pain. Just being prescribed opioids for a medical condition is not a use disorder. So people with a prescription may develop a physical dependency, which is the tolerance. They may need larger amounts of opioids or higher level of prescription in order to get pain relief, and they will have a physical dependency. A withdrawal syndrome if they stop. But they don't have any of the other criteria, which both Cece and I have gone over. Craving, are you taking more or longer? Do you have to go get it from from the street corner? or steal, and are you having consequences, family or any other psychosocial issues as a result of your use? So because of the difficulty defining the difference between dependence and use disorder, we required, well, not we, but the DSM-5 requires two criteria other than tolerance and withdrawal to make it count as a use disorder. So that's about all I have. I will turn it over to Dr. Weiner to bring us home with some harm reduction.
All right, thank you. Just as we're a little bit behind schedule, so all that means is when I leave at 1, Dr. Moreno and Dr. Shack will take more of the questions without me. You guys can do it. I know you can. All right, so hopefully you're seeing my screen now. And just to kind of underscore again, the number of overdose deaths related to drugs is now somewhere between 100,000 and 120,000, per year. For those of you who've been to a University of Michigan football game, that's like the entire stadium of people dying every year, and it is 100% preventable. If you look at the country, the more orangish colors here are where things are getting worse. The bluer where it's getting a little bit better. It's still overall more on the orangish and brown colors. So we're still heading in the wrong direction. Again, as was stated earlier, the synthetic opioids, mostly the fentanyl and fentanyl type drugs, are one of the factors at the root of the overdose crisis. They're probably a major driver. There's also a lot of other issues that I won't get into, like lack of appropriate treatment and identification. And what we're starting to see throughout the country is an increase in overdose deaths related to just stimulants, which are mostly methamphetamine and cocaine. So these are picking up as causes of death, and we're not talking about those much more today. I won't go over the numbers in too much great detail here, but the average person who dies in Michigan is a white male between 25 and 50. But if you notice, there are children dying below the age of 15 and elderly people dying of overdose as well. So the way that we treat any sort of addiction is to try to use a biopsychosocial and spiritual approach to treatment. Biological aspects are immediately, it's really important to deal with the withdrawal. And the drugs that we've talked about here all have a dependency. And patients who are in withdrawal are just very, very uncomfortable. It is very hard to treat them if they are in active withdrawal. It can, if you're in a very structured environment, a lot of drugs, people can go through withdrawal safely. Opiates, people don't usually die from opiate withdrawal. But alcohol withdrawal and benzodiazepine withdrawal, patients can actually die if not medically treated, as was stated earlier. The psychological aspects of treatment is basically rebooting the way people think. You have to, in order to get successful treatment, patients have to identify new ways to deal with emotions and other things that have triggered them for addiction. Therapy is often a very important part of this, although then it's really hard to get therapists these days. There's not enough of them. And in some cases, patients need to be in a structured environment, such as a treatment center, which is where the psychotherapy begins. On the psychological aspect, some of the medications appear to reduce cravings, craving is a very strange term. We don't know how to identify it exactly, but it has a lot to do with the obsession and compulsion. And some of the medications that we give patients for opiate use disorder and for alcohol use disorder appear to reduce cravings. And definitely there's a subset of patients who need professional psychiatric help and need to see a psychiatrist and psychotherapist. We have found if patients have a mental health issue and an addiction issue, they really don't get better unless we treat both of them at the same time and aggressively. The social aspects, again, oftentimes patients who have been dealing with addiction have a lot of toxic relationships and are connected to, I guess, the other people who are engaged in the addiction. And it's really important to develop new friends, new social relationships. Sometimes, again, patients who have severe dependency and are not responding to other treatments, it makes sense for them to be in a treatment center, like a residential treatment center. Oftentimes, the social relationships that seem to help our patients start in mutual self-help groups like AA, NA, Al-Anon, Refuge Recovery, Celebrate Recovery. These are all versions of usually 12-step type groups. But there are other places that people can make social connections. There are spiritual groups in church and temples and things like that. And often patients look for a purpose, and they find a purpose. They start to feel a lot better. I just want to familiarize the people who are here with some of the treatments, because there are some questions about them. I'll go over this fairly briefly. One of the treatments, and the oldest treatment for opioid use disorder, is methadone. Methadone is a long-acting opiate. It does not affect the addiction center in the same way that fentanyl and short-acting opiates do. It stops the withdrawal. One of the downsides, especially in the age of fentanyl, is that because the opiates are so potent, it may take several weeks for methadone to actually reduce the withdrawal to a manageable level. And sometimes patients continue to use illicit drugs when they're on methadone. It is just part of how things happen. It does seem to reduce cravings, as reported by some patients. It is only available now through methadone clinics, which can be disruptive to patients' lives and require them to go to the methadone clinic daily, and the taper can be difficult. Suboxone or buprenorphine is another long-acting medication, is a partial opiate, even less affecting the addiction center. It can be given as under the tongue, or it can be injected monthly. It also reduces cravings, reduces withdrawal. It can reduce withdrawal within hours, and therefore has some benefits over methadone. Overall considered safer than methadone. Taper is still difficult, but probably less so than methadone. And naltrexone, which is an opiate blocker, completely blocks opiates, at least it tries to. I think some of the new potent synthetic opiates probably can overcome naltrexone, but it can be given orally or by a monthly injection. The main difficulty is that patients have to be abstinent for 1 to 2 weeks from opiates before you start this. So the average person who's actively using, this is not the first thing that they can use. Otherwise, it will make them get them very, very sick. Good settings or common settings for the use of these drugs are at the end of a treatment, when someone's been in residential treatment, or when they're paroled out of a lot of incarceration, where hopefully they haven't been using. These are good times to start medications like this, and it also reduces craving for alcohol. But I want to talk a little bit in a few minutes about nasal naloxone or Narcan rescue. So just to kind of clarify, the reason people are dying from opioids is that the opioids, when they're in the body, migrate to all parts of the body. They go to the brain, and they tell the brain to stop a very important function of life known as breathing. And so when breathing stops, as you know, we don't live very long. And the most important thing we could do is try to reestablish breathing. And one way to do that is to block the opiates. And naloxone can do this. It's a short-acting blocker. It can be given by nasal injection. It's one of these things that if we give it to a patient who is, our normal breathing rate is 10 to 20. When someone is dying of an overdose, their respiratory rate may be somewhere between 4 and 0. So we're not breathing enough. And the idea is to get them breathing again. Of course, CPR and these things can work as well, but this can work additionally. And I carry Narcan because I get a lot of it for free from different places, and you guys can too. You'll find out in a minute. I take it to my kids, the football games and events. You never know where you're going to run into somebody who's overdosing, and you can save their life. You can get this nasal naloxone at any pharmacy without a prescription in Michigan, although it may cost you. However, there are many, many free services, free places in Washtenaw County where you can get it either delivered to you, or you can even pick it up. In Ann Arbor, all district libraries offer free Narcan. The fire departments have it available. And if you go to City Hall, the City of Ann Arbor, basically the City Hall building on East Huron, they have a vending machine where you can get free naloxone. It's pretty easy to use. This slide may be all you need to know, but if you go to the Narcan.com resources, you can watch a 4 to 7 minute video, depending on which ones you want to look at, which kind of show you how to identify someone who might be having an overdose. And sometimes it's pretty easy. there's a needle around, there's a needle in their arm, or they for no reason, a healthy person has passed out. You can spray this in their nose. The most important part here is when this happens, you probably want to call 911 as it's happening on speakerphone while you're using the Narcan rescue. You don't want to, this is not a substitute for calling EMS. The Narcan does wear off and may wear off within 30 minutes or 60 minutes. You definitely want EMS available when this happens. This slide will be sent out to you, just showing you some local resources for addiction treatment for both teens and adults. And that concludes our talk, my talk. All right, I'm gonna stop sharing. And I will take a question or two, and then I gotta go. So I think, how are we doing that?
So Dr. Moreno has done a wonderful job, and I think Dr. Shack too, you may have gotten a few answers in there of typing some answers. I'm going back to see if there's one that maybe we want to call out publicly just to share the answer with everyone.
Good ones. One was asking whether the medications that were used for opioid withdrawal could be used for alcohol withdrawal as well. I answered that in the chat, but you might want to answer that, Dr. Weiner, or I can answer it, either one.
I mean, yeah, the naltrexone injectable can be used for opiate withdrawal and alcohol withdrawal. However, most of the opiate withdrawal, opiate medications like buprenorphine, or Suboxone, and methadone are not recommended for alcohol withdrawal. It's a different receptor, a different basically part of the body that they act on, so it does not work.
Okay, another person was talking about their son who attempted suicide in January, and they moved him home to be with them. And they asked, could his marijuana use be a contributing factor to his attempted suicide? And I don't know if you'd like to chime in on that, Dr. Moreno.
I saw that question. I'm glad we answered it. You know, first, again, sorry that you had to deal with that as a parent. I can't imagine how challenging that must be. But I'd have to say that as information emerges, it does appear that use of cannabis and cannabis products increases the risk of all mental illnesses, probably worsens existing mental illness. And I would say the paranoia and suicide attempts are not an uncommon thing that we hear about for patients who are using cannabis products. Now, one of the things that, despite all the information that we have about cannabis for many, many decades, the fact that the percentage of THC is so high now, we are really dealing in the Wild West. We do not know what these potencies of THC do to the human brain. And unfortunately, the legalization, you know, on one hand, I don't believe in criminalizing addiction. It is a medical issue. On the other hand, we are exposing a lot of our kids and adults to levels of drugs that we don't know what it does to the human brain. And we're going to find out the hard way in years to come, sadly. And at this point, I will have to go. And if there are more questions, I will leave it to Dr. Shack and Dr. Moreno. Thank you for having me.
Thank you so much, Dr. Weiner. We appreciate you being here.
Thanks.
Okay, so ladies, I thought maybe again let's go back. Okay, so there are actually some new questions, so maybe we can answer a couple of those live. Again, if you want to type your answers, that's okay too. But let's try to chat through some of these, and we'll maybe stay on for another 10 to 15 minutes. Is that okay with both of you? Okay, perfect. So how do you get someone to want treatment? It's a great question.
I can answer that. One thing that we find is a key component for treatment is willingness and acceptance for treatment. And so I would say, you know, you can't force anyone's hand for treatment, but you can definitely indicate to that person actual evidence of their use and what it has caused in their life, like the repercussions, like show them, hey, you're no longer working, you're no longer doing what you used to do. We're always arguing, X, Y, and Z. So I would say present a case to that person and just continue to try, offer loving support. But then ultimately the decision is up to the person to whether they want treatment or not.
Okay, so do you have are there like conversation starters that have worked well for other patients and their families, or things that people can, I don't know, use to kind of initiate that first conversation?
There are a couple of different methods. When we're talking to patients as physicians, a lot of times we'll use a technique called motivational interviewing, which is basically we ask the patient, what impact has this drug or substance had on your life? Can you see any benefits? What has it done to benefit you? A lot of patients respond to that because they feel like they're getting some benefit from the substance or they wouldn't be using it. And then asking them, how has it harmed you? How, what would your life look with like? What would your life look like without the substance? And things like that. From a family member, I can imagine that it would probably be very difficult to broach that subject, and any approach that asks them how the substance was hurting them or something like that may be perceived as kind of blaming them or not received well. So maybe sticking to this impacts me because of X, Y, and Z, and this has impacted our relationship. Keeping it self-centered versus blaming. Those are just my thoughts.
Yeah, just to add to that, like I would say also taking a non-judgmental approach. I'm pretty sure this person is also having some their own self-judgment, and there's a part of that person like being aware that this is a harmful, but they may not be willing to admit it. So keeping it loving, non-judgmental, I would, look and see if there's any motivational interviewing techniques for family members, and that might be an option. Like Dr. Shack mentioned, we do use that technique as clinicians. So,
Okay, perfect. What can you do for a benzo withdrawal? Same as alcohol?
So commonly, people say that alcohol withdrawal is only a life-threatening withdrawal, but benzodiazepine withdrawal is threatening as well because it binds to the very similar, to the same receptor in a different way as alcohol. So that would be something that you would want to consult an MD or a DO prior to going through the withdrawal. And I answered the question about can opioids be used to, or like buprenorphine or methadone for alcohol withdrawal. This is a situation where alcohol medications can be used for benzodiazepine withdrawal. It just needs to be in a supervised setting, whether inpatient or outpatient.
Okay. I'm going to pronounce this medication incorrectly, so bear with me. Can more than one dose of haloxone be given to someone? Does that make sense?
Narcan, naloxone. Yes,
it's with an H. Is that wrong? Should it be an N?
it was just a typo.
Got it. Okay, perfect. Thanks.
Absolutely, yes. Especially in the age of fentanyl. You want the person to breathe. You don't want them angry when they wake up. And so, I mean, don't give them like 10 doses of naloxone. But, if they don't respond from the first dose, it might take more than one dose, up to, 3 or 4 doses to get them to breathe. And I think another important thing to mention with harm reduction is that the issue is breathing. And so as long as their airway is clear, if you have access to an ambu bag or something like that, and you have, CPR training, anything, you can actually breathe for the patient, and that might help a little bit with harm reduction in addition to the Narcan.
Okay, perfect. And what makes alcohol withdrawal deadly?
So you can have a seizure. And also there's another disorder called delirium tremens. And that is when a person becomes altered. They don't know where they are. They might be hallucinating. They are having seizures. They also have hypertension, increased heart rate. So with this, there's an increase in mortality overall. Patients might fail to protect their airway. They might need to be intubated. And then with that overall, just the constellation of these symptoms increases the mortality and death in patients who are withdrawing from alcohol.
Somebody was asking earlier, mentioned that it was kind of hard to find therapy or care for their loved one. And I know there's another question in here. It seems like all behavioral specialists that specialize in addiction are not taking new clients. So do you have some advice on how you can find a resource for someone or yourself if you're suffering from addiction?
I was typing an answer for that just now, but I was going to say, because the person asked, the person has addiction and anxiety disorder. Yes, there is a huge need for therapists who treat addiction. However, if you cannot find a place or a therapist who has an opening, I encourage you to still find a therapist that treats mental illness. So most patients who have substance use disorder are usually struggling with depression, anxiety, or even trauma. So if you can find a therapist who might not be specializing in addiction, but does specialize in trauma or depression, anxiety, then go ahead and see that therapist. So that's my recommendation.
I would add many addictionologists are taking patients. And so, like Dr. Moreno said, if you can find a therapist that can handle anxiety and depression, and then you also add the component of seeing an addictionologist, and you have your addiction issue, at least partially taken care of. And so I think with the treatment, it's about adding those multiple layers. And, we mentioned several different types of mutual help groups. If you don't like the 12 steps, try the SMART. They're not therapists, but they can also add a level of support that may help with your anxiety and depression, and a little bit of support until you can get in with someone that you want to see.
And if you are in an emergency state, of course, you can go to the emergency room and seek those resources as well, correct? And our IHA medical group recovery medicine program is available at the hospital in Ann Arbor, Livonia, as well as Pontiac at Oakland, Trinity Health Oakland. Okay, are there any cannabis withdrawal symptoms, and what are they? Is excess sweating one of them?
That's a great question. And yes, there are cannabis withdrawal symptoms. Sweating is one of them. So as you know, cannabis or marijuana causes increased appetite. So when you stop using the substance, you might have decreased appetite, mood changes, irritability, sleeping difficulties, insomnia, increased anxiety, headaches, poor concentration, cravings also to return to use, chills, and then depression and stomach problems. So you might get stomach pain, vomiting, nausea also when you stop cannabis use.
And how do you know if you're working yourself to try to stop using either cannabis or cigarettes or what have you? How do you know when you need some medical help to really stop that addiction?
That's a great question. I mean, I don't know if Dr. Sheck, you want to answer that, but yeah, go ahead.
I would say if you're sitting there thinking, do I need some medical help for this? Then you probably do. If it's started to impact your life and you can just check off, okay, is even like 2 of those criteria, I would say seek help and seek help early, because I've never seen anyone not seek help for a use disorder and get better on their own, like without some kind of intervention, either, social or medical or, whatever, some kind of help. We're social beings. We need help. So.
Okay, great.
And I just wanted to add to that. We do also, we've had a couple patients come into the clinic and they thought they might have a problem, and we will determine and see if you meet those criteria. And some people actually didn't. There might be some people who are just overly anxious. There's people who come in because they are aware of the opiate crisis and they're like, I don't want to be addicted. And am I addicted? And they, we find out, we tell them, no, you're not. You're actually having anxiety. We have our office as a resource. If you have any questions, we have open up spots, Dr. Scheck, myself, and the rest of the IHA recovery medicine group. You can come in, make an appointment.
And the best way to do that is a phone call, I imagine. So I will share that phone number. You can also access it by going to the website, ihacares.com, and then to specialty recovery medicine, and you will see 3 locations as well as the phone number, which should be the same for all. Okay, would it be fair to say that an addiction is a manifestation of a mental health condition?
No, not necessarily, but patients with mental health conditions such as schizophrenia or depression, anxiety are more likely to have issues with addiction. I'll turn the rest over to Dr. Moreno. She's the psychiatry person.
So that's a complex question. I feel like because substance use disorders or addiction, their criteria are actually in the diagnostic manual of psychiatric and mental health conditions, the DSM-5. Psychiatrists are equipped to also address substance use, but as we become more and more aware of the nuances of addiction, like for example, the definitions changing, you can consider it a mental health condition, or you can consider it a separate new entity on its own, where it's a chronic medical condition. But what Dr. Scheck said is correct. It's not considered like, oh, I use opiates, therefore I have depression. But as she mentioned earlier, like depression can be a risk factor. It can be a reason why someone turns to opiate use or any other substance use, or it could be where this person used the substance and then they end up having depression secondary to the substance or whatever illness like anxiety. So it's a complex disease process with complex answers, I believe, but that's a good question.
If you are someone who does not have an addiction currently, but maybe you do have a mental health condition, whether it's anxiety or depression, as you noted, is that something you want to make people aware of when you're going in for procedures like even a colonoscopy or things like that, because it may change the way or the type of drugs you're administered? Are those risk factors something you should keep known to like your medical professionals?
It depends on the procedure. We have patients come in and one person told me they had a knee operation and then they were given that short course post-op of opiates. And next, it was a problem ever since after that. Who can predict that will happen though? If someone wants to be very prudent in their medical care, they might mention to their surgeon or whoever's doing the procedure, hey, I have a family history of addiction. Hey, I have depression, but it's XYZ. I would say just keep it, they can see your chart, but also if you're in getting care from a different health system that doesn't use the same, electronic medical record, then yes, mention all of it. If you're concerned about if it's on your mind, because stress also can adversely affect outcomes of surgery or procedures, then mention it. And let the doctor, be the one, to give their opinion as what to do next. But that's a good question.
Okay. And then finally, I know we've had a couple questions from family about how to address someone who they think, or friends who they think may have an addiction. So if you've already maybe approached this person once or twice and, they're denying their addiction, do you have any recommendations or methods that people could use to kind of continue to address it? My thought is that you shouldn't give up. So how do you kind of keep addressing someone who's in denial?
I would probably start attending a meeting like Al-Anon or Nar-Anon for yourself, because when the patient's addiction starts impacting their life to a significant amount then they're going to have to make the change. But if they're not ready, there's no amount of times that you can approach the patient. I mean, you don't want to stop and leave them alone, but it really becomes an issue of you being able to deal with the fact that you have someone in your life that has a problem with substance use disorder, versus fixing the other person.
And can you take a person who has an addiction to the emergency room? Okay, so that is something you can
Absolutely.
do. Okay.
Yep, and if they, they may not meet criteria for admission, but even at Trinity Health Livonia, we have um, early access appointments for patients that have alcohol use that may not need to be admitted, but they really need to see an addictionologist the next day to help with withdrawal management, and we can refer you there. And they can do that from Ann Arbor, refer you to anyone virtually or in person as well.
Okay, that's a great resource to share.
Yeah. And it's not just alcohol, it's all substances we will see. I also want to point out that, some people we've had, say that they bring a person in to treat their substance and they kind of want them to be committed or held as if it was a psychiatric illness. That's the difference with addiction. With a substance use disorder, the person can, you bring them into the ER, but we cannot hold them against their will. If they are not willing to have treatment, we can, they can leave. It's not the same as with someone who is, is depressed and, threatening to harm themselves or someone else. So if they're threatening to hurt themselves or someone else, although family members would argue drinking is hurting themselves, yes, I agree. But under the current laws, medical laws, we cannot keep that person against their will.
I liked your advice of kind of seeking help for yourself, whether it's mental help or a local group, of really trying to understand how to live with someone who is addicted and be able to kind of continue your own life, because that's got to be a really hard position to be in. We did get one more question, if you don't mind me answering it. It was a functional addict who mostly binged. He could hold a job. They could hold a job, but their behavior was always unpredictable. Stopped using in 1985. Sometimes they think they would like a drink, but don't know if that would suck them back in. What do you tell people who are recovering? Can they drink at Christmas time or on other occasions and do that safely?
Sorry, did you want to answer that?
Go ahead.
I mean, I think anyone with one use disorder is always at risk to develop another use disorder. So I mean, it's risky, but not strictly contraindicated. However, I've seen patient after patient that had one use disorder and took a drink and had another drink and eventually developed an alcohol use disorder, or with alcohol use and eventually developed another use disorder. So I personally, if it was my situation, I probably wouldn't risk it, because I don't know whether there's any benefit to having one drink that would have me risk dealing with a use disorder. That's my personal opinion.
I will say that the recovery model has shifted. It has come from, early on when the whole addiction medicine landscape came about. There was abstinence was very pushed, abstinent model, being abstinent, even going to AA meetings for patients. If they weren't abstinent, they might be looked upon in a different way. And then also when it comes to opiate use disorder, they had to stop, and it's the patients who are on buprenorphine, Suboxone, methadone were considered fully recovered. There has been a shift. There's a lot of talk about it. And comes in under the harm reduction model. Like, what is recovery? Is it abstinence only, or is it using, this person has now shifted to using a substance in a responsible manner? So I have, there, you have to look and search, your own behaviors and see, are you a person that can go towards responsible use? Can you put have one drink at Christmas and put it down and not pick up another? Like Dr. Scheck said, it's very risky. If you feel like you have an addictive personality or you've had a history of addiction with that substance, and then you are, risking to see if you are a person that can have one drink and put it down. I do have some patients who have returned to casual use, and I still consider them in remission because it's no longer a use disorder. It's no longer disrupting their life, their work. They're not craving it. However, Dr. Scheck said, it's a risk. And, if you feel that you can't take that risk, then you might have to stay away from it permanently.
And just to belabor this a little bit more, I would say that part of being in recovery is being able to think through that whole process. That means that your brain has healed to the point where substance isn't controlling you, where you can think about the benefits and the risk of, taking that one drink at Christmas. That's part of the process of being in a recovery situation.
Those are great points. And 1985 is a number of years ago. So you're right. Yeah, you could be in a completely different place.
Yeah.
But that's a wonderful thing.
Congratulations.
Yes.
And then what is the difference between alcohol use disorder and full-on alcoholism? Is there a difference?
It's a nomenclature thing. Basically, they used to call it alcoholism, and now we refer to it as it's the same thing. Alcohol use disorder, and there are different levels of severity, so mild, moderate, and severe. And I don't know what you're counting as full-on alcoholism, but it's probably severe alcohol use disorder now. So it's just, same thing by a different name, more polite.
Okay.
And less stigmatizing.
Yes, definitely. Yeah, it has a little more of a medical ring. And do you treat eating disorders, or is that purely mental health?
So that's a great question. Eating disorders are addressed under mental health. They do respond well to medications like antidepressants and cognitive behavioral therapy. So if you do have an eating disorder, I would suggest that you go see a psychiatrist. Dr. Rifkin has one of our addiction medicine specialists in our group has seen a few patients with eating disorders. However, he almost always refers that person also to a psychiatrist. So I would suggest psychiatry.
Okay, perfect. And of course, if you're very concerned or you think that you are in a place where your life is in danger, the emergency room is always the right stop. Okay, perfect. Thank you both for being here today. This was this is full of such good information, and I'm so grateful that you were here to share it with our patients. So we appreciate you guys, and I will again follow up with everyone who was on the call, and also those who registered but weren't able to join today, that they would be able to see the recording in their email in just a few days, as well as some contact information and some of those other resources you guys shared throughout your presentation. So thank you both so much, and good luck with the rest of your fellowship.
Thank you for having us.
Yes, thank you.
All right, have a good day.
You too.
Bye.